You know, usually when we talk about diagnosing some kind of medical emergency, we just assume the blood tests are going to be screaming at us, right?
Absolutely, like a fire alarm going off.
Exactly. Like the numbers on the page are either going to be wildly high or just terrifyingly low. And then the doctor points at the chart and says, well, there's the problem right there.
Right, because we desperately want medicine to be objective. I mean, we rely on those laboratory thresholds to tell us exactly when a chronic, manageable issue has suddenly crossed the line into an acute, life-threatening crisis.
But then you look at the extreme edges of endocrinology, and suddenly the blood tests are basically lying to you.
Yeah, they really are.
Which brings us to our mission for today. Welcome to the deep dive, to you, the learner listening right now. Today, we are looking at this fascinating stack of medical and historical sources to explore the terrifying tipping points of thyroid disease.
It's a wild ride, honestly.
It is. We're looking at thyroid storm and myxedema coma. These are the exact moments when a totally manageable hormonal imbalance transforms into a catastrophic, organ-failing emergency. This deep dive is built for your curiosity, I promise. We are connecting 19th century surgical mysteries straight to modern ICU debates.
I love how these histories connect to what we still struggle with today.
Same here. Okay, let's unpack this, starting with what these two conditions actually represent fundamentally, because if I'm reading this right, they are essentially mirror images of each other.
They are, yeah, they represent the absolute decompensated extremes of thyroid disease. So thyroid storm is the catastrophic amplification of hyperthyroidism.
Meaning a massive overload of thyroid hormone activity.
Well, exactly. And then myxedema coma is the exact opposite. It's the catastrophic collapse of hypothyroidism, so a profound lack of hormone activity. But the absolute most crucial thing to understand about both of these states is that they are clinical diagnoses.
Not lab-based diagnoses.
Exactly. They are not lab-based. And that's what trips people up.
And this is the misconception that I found so fascinating in the sources. Because you could have a patient in the ICU, actively dying of a thyroid storm, and if you look at their free T4 or T3 hormone levels on a lab printout, those numbers might look absolutely identical to a patient who is just walking around the grocery store with perfectly stable hyperthyroidism.
It's totally counterintuitive.
Right. And just to level set for a second, T4 is essentially the inactive storage form of the hormone, and T3 is the active driver of the body's metabolism, correct?
That's right. T4 is the pro-hormone.
Yeah.
So your body converts it into T3 when it needs to turn up the metabolic engine.
Okay, got it.
So intuitively, you'd expect the patient in a fatal crisis to have just drastically higher T4 and T3 levels in their blood than the stable outpatient. But frequently, they just don't.
So what's actually happening then?
Well, the difference isn't necessarily the raw amount of hormones floating in the bloodstream. The difference is that in a storm, the body's entire systemic buffering capacity has just completely collapsed.
Okay, so what are those buffers doing normally when things are fine?
Well, most thyroid hormone in your blood isn't just floating around freely. It's tightly bound to these carrier proteins, which keeps it inert until it's actually needed.
Ah, okay. Like keeping it in storage.
Right. So in a stable hyperthyroid patient, the body adapts. It might increase those binding proteins or, it might downregulate the sensitivity of the receptors on the target organs. It actively limits how fast that T4 gets converted into active T3 in the peripheral tissues.
It's protecting itself.
Exactly. But in a storm, all those safeguards fail simultaneously.
The way I'm picturing this, it's like a car engine.
Oh, I like that.
Yeah, like if you have stable hyperthyroidism, it's that somebody is pushing down a bit too hard on the gas pedal. The engine is revving way faster than it should, sure. But the car's cooling system is still working. The brakes are functioning, the transmission is holding together. You can still drive the car safely, even if it's running really hot.
That's a perfect way to look at it. And to push that car analogy even further, a thyroid storm isn't just someone pushing the gas pedal all the way to the floor. It's the exact moment the cooling system bursts, the brake lines snap, the transmission blows, and the entire car violently shakes itself apart at the seams.
Wow, just total mechanical failure.
Right, it's the failure of the containment systems, not just the gas pedal.
And you really see that violent shaking apart in the actual clinical symptoms. Because a thyroid storm is defined by this pattern of multi-organ decompensation. We're talking extreme fevers, often like 104 to 106 degrees Fahrenheit.
Which is incredibly dangerous on its own.
Yeah, and the heart is racing well above what the thyroid levels alone would actually predict. You see profound altered mental status, going from severe agitation all the way up to acute psychosis. And then gastrointestinal or hepatic failure, so vomiting, diarrhea, jaundice.
It's a complete systemic meltdown. And then, on the exact opposite end of the spectrum, we have Myxedema Coma, where the engine isn't revving, it's completely freezing over. It is the absolute endpoint of profound hypothyroidism, though the name itself is actually a bit of a historical trap.
Right, because they aren't necessarily in a coma, are they?
No, actually.
Right.
Most patients present on a whole spectrum of altered consciousness. Like, they might be severely lethargic or confused or stuporous, but a true unresponsive coma is fairly uncommon.
Good to know.
But underneath that lethargy, nearly every single organ system is aggressively depressing its function. You see profound hypothermia, the heart rate just plummets, gut motility becomes super sluggish,
Yeah.
and critically, their respiratory drive is blunted, which leads to them retaining dangerous, sometimes fatal, levels of carbon dioxide.
That is just terrifying.
It really is.
And what's wild to me is that because these are clinical diagnoses, based on looking at a crashing patient and not a lab result, medicine actually figured out what these diseases were long before we had modern blood tests.
Oh, yeah.
Doctors basically had to learn this the hard way, in the dark, during surgery.
The history here is incredibly visceral. I mean, if we go back to the late 19th century, surgeons were operating on the thyroid gland before anyone actually understood what the thyroid did at a biological level.
Which just sounds so crazy today.
Right. They were removing enlarged thyroid goiters, often just because they were mechanically blocking the patient's airway, or even just for cosmetic reasons.
Right. And then enter this Swiss surgeon named Theodor Kocher, who eventually won the 1909 Nobel Prize for pioneering safe thyroidectomies. But he noticed something horrific happening to his patients when he removed the entire gland, right?
Yeah, it was a major problem.
They didn't just heal and go back to normal life?
No, he saw them develop this strange, swollen, profoundly mentally slowed state. He called it cachexia struma-priva. And this was a massive breakthrough because it was the key piece of evidence proving that the thyroid wasn't just some, vestigial lump of tissue in the neck like an appendix.
It actually did something.
Exactly. It actively produced something that was absolutely essential to human survival, thermogenesis, and cognition.
And then around that same time, in 1877, you have a British physician named William Miller Ord who was seeing a similar severe slowing down in adults, but this was naturally occurring, not from surgery.
Right.
He noticed they had this very specific dry skin and a non-pitting swelling. And he actually figured out the swelling was from mucin deposits under the skin. So he coined the term myxoedema, which comes from the Greek words for mucus and swelling.
And as the decades went on, doctors started to notice a very dark pattern with a subset of these myxedema patients. Often it was older women, usually in the dead of winter. And they would slip into this hypothermic, unresponsive state. The mortality rate was staggeringly higher than just ordinary baseline hypothyroidism.
They were finally identifying the total systemic collapse.
Exactly.
But the hyperthyroid side, the thyroid storm side, has an origin story that I think is even more dramatic, mostly because of the surgical crisis in the early 1900s. The mortality rate for operating on a patient with active Graves' disease, the autoimmune disease that causes hyperthyroidism, that mortality rate was approaching 50%.
It's hard to even wrap your head around that.
Yeah, half the patients were literally dying of post-operative thyroid crisis.
Just imagine being a surgeon at that time. You're trying to help someone whose gland is dangerously overactive, but the mere physical stress of cutting into them triggers this massive metabolic explosion right on the operating table or in the recovery room. They just didn't know how to biochemically cool the gland down before surgery.
Until a massive breakthrough at the Mayo Clinic around 1923 by a doctor named Henry Plummer. He introduced this idea of giving the patient a preoperative iodine solution, which later became known as Plummer's solution.
It was a game changer.
Just by giving this specific iodine preparation before taking them to surgery, it calmed the gland down and completely slashed those surgical death rates.
If we connect this to the bigger picture, we really need to understand the underlying physiological substrate of these crises. Like, why did the surgery cause the explosion in the first place, and why did Plummer's iodine actually work?
Right.
It all comes down to this crucial concept in endocrinology called the second hit.
Right, because nobody just wakes up on a random Tuesday and instantly develops a thyroid storm from scratch. You have to have a pre-existing condition.
Precisely. Both of these conditions require an underlying chronic thyroid disease to already be present. That is the first hit. So for storm, it might be Graves' disease or a toxic multinodular goiter. For Myxedema Coma, it's often prolonged, untreated Hashimoto's thyroiditis.
Okay, so what's the second hit?
The second hit is an acute stressor layered right on top of that fragile baseline.
So for those early 1900s patients, the surgery itself was the massive second hit.
Yes, exactly.
But it could also be a severe infection, physical trauma, childbirth, or even abruptly stopping antithyroid medications, right?
Absolutely. Any major systemic stress.
But what is actually happening at a cellular level when that second hit lands on a hyperthyroid patient? We mentioned the free hormone spikes, but the sources talk about this terrifying mechanism called adrenergic synergy. What is the thyroid hormone actively doing to the body's adrenaline?
This is where the physiology is just brilliant but deadly. Thyroid hormone doesn't just increase metabolism directly. It physically upregulates the body's adrenergic receptors.
Meaning what exactly?
It literally commands the cells, especially in the heart muscle and the nervous system, to build more receptors for adrenaline and noradrenaline.
Wow. So even if your actual adrenaline levels are completely normal, your heart is suddenly covered in extra microscopic satellite dishes, picking up every single molecule of adrenaline and totally overreacting to it.
Exactly. The thyroid hormone turns the volume of the fight-or-flight system up to 11. So when that second hit occurs, say a massive infection, the body naturally releases adrenaline to fight it. But because the heart is hypersensitized by the thyroid hormone, it responds as if it's being hit with a lethal overdose of adrenaline.
Oh, wow.
That is exactly why the heart rate goes dangerously high and why patients become delirious or psychotic.
That perfectly explains why the frontline treatment for a thyroid storm isn't just about targeting the thyroid gland. You have to aggressively target the sympathetic nervous system with beta blockers, like right away.
Yes.
You have to put shields over all those extra satellite dishes on the heart to block the adrenaline synergy before the heart just shakes itself apart.
That is exactly the mechanism. You use beta blockers to stabilize the cardiac output while you work on turning off the thyroid engine itself.
There is a fascinating concrete example of this adrenergic effect on the heart involving a very famous patient. In 1991, U.S. President George H.W. Bush developed an irregular heartbeat atrial fibrillation.
Right.
And it was discovered that this was the direct result of him having undiagnosed Graves' disease. The hyperthyroidism was accelerating his heart.
And remarkably, First Lady Barbara Bush was also diagnosed with Graves' disease around that exact same time.
Which is an unbelievable coincidence. Investigators at the time heavily looked into environmental exposures or water contamination at the vice president's residence to try to explain it, but nothing was ever conclusively proven.
Still a mystery.
Medically, though, the president's case is a perfect real-world illustration. Because even outside of a full-blown thyroid storm, in just a stable, non-crisis form of Graves', that adrenergic amplification is targeting the rhythm of the heart. It shows you the exact pathway that eventually leads to a fatal storm.
It really does. Now, if we flip the coin and look at myxedema coma, the mechanics are the reverse, but honestly equally dangerous. Instead of a hyperamplified system, you have a total loss of reserve capacity.
Right, the engine freezing over. Because chronic severe hypothyroidism slows the metabolic rate of every tissue in the body. The mitochondria simply do not have the T3 hormone they need to generate cellular energy.
And when that patient gets their second hit, say, they develop pneumonia. The body's reserve capacity just collapses. The core temperature plummets, sometimes dropping below 90 degrees Fahrenheit because thermogenesis has just totally failed. Cardiac output falls, the brain slows down.
And there is a chilling detail here about how deceptive this is, like literally chilling. Normally, if you were to develop severe pneumonia, your body mounts an inflammatory response. You get a fever.
Of course. But in myxedema coma, the metabolic state is so profoundly depressed that the body physically cannot generate the heat required for a fever.
It's wild to think about.
A patient could be sitting in the emergency room in myxedema coma, triggered by a massive life-threatening infection, and they might have a completely normal temperature.
And to you, listening, think about how dangerous that is. A normal temperature in that state is actively misleading to a doctor. It's masking the fact that the house is on fire because the smoke alarm literally doesn't have the battery power to ring.
That lack of physiological signaling is exactly why these conditions are so notoriously difficult to manage, which leads us directly into the massive debates happening in modern intensive care units today.
Let's get into those debates, because this is where the rubber meets the road. If we understand the cellular mechanics so well, the adrenergic synergy, the blunted fever response, why do these conditions still kill a substantial fraction of the people who get them today, even in a state-of-the-art ICU?
The primary reason is that the exact tipping point between very severe disease and lethal crisis is still incredibly hard to define in real time. Because it's a clinical diagnosis, endocrinologists have tried to formalize the rules using scoring systems, just to force doctors to recognize a thyroid storm before the patient dies.
Right, the most famous one being the Birch-Wartofsky Point Scale, or BWPS, introduced in 1993.
Yes. The BWPS assigns points across 5 domains. So you look at temperature, central nervous system effects, GI or hepatic dysfunction, cardiovascular dysfunction like heart rate or atrial fibrillation, and finally, whether there's a known precipitating event. If a patient scores above 45 points, it is highly suggestive of a thyroid storm.
So if someone skips their thyroid medication for 2 weeks, comes into the ER with a fever of 103, a heart rate of a 140 with new AFib, and they are agitated, they blow right past that 45-point threshold, even if their lab work looks somewhat typical for hyperthyroidism.
Exactly. But here is the debate. Birch and Wartofsky explicitly designed their scale to prioritize sensitivity over specificity.
Okay, meaning?
They wanted to cast an incredibly wide net and flag as many true storms as possible, fully accepting that they would accidentally flag some patients who were just very sick with hyperthyroidism, but not truly in a systemic crisis.
The philosophy of better safe than sorry in critical care.
Right. But there is a rival scoring system from the Japanese Thyroid Association, introduced around 2012.
Yeah.
And their approach prioritizes specificity. They require documented thyrotoxicosis plus objective, hard evidence of central nervous system or cardiovascular dysfunction.
So you have a live disagreement in modern endocrinology.
Oh, absolutely.
The American BWPS might cast too wide a net and overcall an impending storm, subjecting patients to aggressive ICU treatments they might not even need. But the Japanese system is stricter and risks undercalling a real one until it's too late. You could have the exact same patient, and the two scoring systems will literally disagree on whether they are actively dying of a thyroid storm or not.
Which really proves the point that even today, thyroid storm is a constructed clinical category. It's a medical judgment call, not a hard biological line.
Okay, but I have to push back on a major contradiction regarding the treatment itself.
Okay, shoot.
Earlier, we talked about Henry Plummer in the 1920s. We said he saved surgical patients by giving them iodine before surgery. But modern ICU protocols explicitly warn that giving iodine to a thyrotoxic patient is a trap that can paradoxically make the storm worse. How can iodine be both a historical cure and a modern lethal trap?
It is both.
Oh.
And it all comes down to a crucial biological sequencing rule. It's really a tale of two entirely different physiological effects. If you give a huge dose of iodine to a patient whose thyroid is actively, uncontrollably churning out hormone, the gland simply uses that iodine as raw material to build even more hormone.
Oh, okay, that makes sense.
You are pouring nitrous oxide into an engine that is already redlining. That paradox where iodine worsens thyrotoxicosis is called the Jod-Basedow effect.
So to avoid the Jod-Basedow effect, you have to block the factory synthesis first.
Exactly. In an active thyroid storm, the sequence is a matter of life and death. You must first give a thionamide.
Which is an anti-thyroid drug, right?
Right, like methimazole or PTU. These drugs chemically block the enzyme that binds iodine to the hormone structure. You basically shut down the factory floor first.
You block the synthesis, then what happens?
You wait about an hour for the block to take full effect. Once synthesis is halted, then you administer a massive pharmacological dose of iodine. When you do it in that exact order, the sudden flood of iodine triggers a totally different biological response called the Wolff-Chaikoff effect.
The Wolff-Chaikoff effects. So the gland basically senses an iodine tsunami and boards up the windows.
That's a great way to put it, actually. It's a temporary, self-protective mechanism. The thyroid gland detects the massive iodine overload and hits the emergency shutdown button, temporarily halting the release of all preformed hormone into the bloodstream.
Wow.
So thionamide first to stop production, then iodine to trigger the shutdown. If you reverse the order or give iodine alone without the blocker, you trigger Jod-Basedow and fuel the storm.
It's a literal biological cheat code, but you have to punch the buttons in the exact right sequence.
Exactly.
And speaking of those anti-thyroid drugs, there's another intense medical trade-off with the thionamides themselves, specifically PTU.
Yes, propylthiouracil, or PTU. In everyday stable hyperthyroidism, doctors strongly prefer a drug called methimazole. But in a thyroid storm, PTU is often the preferred choice because it has a special second mechanism of action. It inhibits the delidenase enzymes in the peripheral tissues.
Meaning it blocks the body from converting the inactive T4 into the active T3 driver.
Exactly. It slows down the active hormone at the tissue level, not just up at the thyroid gland. But the paradox is that PTU carries a rare, but very real risk of fulminant liver failure.
Yikes.
Yeah, in a stable patient, doctors avoid it because the liver risk simply isn't worth it.
Mm-hmm.
But in a thyroid storm, the mortality of the storm is so staggeringly high that doctors deliberately accept the risk of destroying the patient's liver because the alternative is letting the storm kill them today.
It's just picking the lesser of two extreme evils. And these debates aren't just isolated to the hyperthyroid side. There is a huge debate in treating myxedema coma, too. When the engine is frozen and the patient is hypothermic, do you revive them with just standard levothyroxine, which is synthetic T4, or do you give them a combination of T4 and the much faster-acting T3?
It's heavily debated. Giving T3 corrects the cellular metabolic crisis much faster because the body doesn't have to convert it. But flooding a severely hypothyroid patient with active T3 aggressively spikes their metabolic rate, which vastly raises the risk of severe arrhythmias and cardiac ischemia. Remember, patients in myxedema coma are often elderly, and their hearts are already incredibly fragile.
So giving T3 might restart the engine way too fast and blow a gasket, while T4 alone is safer for the heart, but takes days to fully work.
Exactly. And it's an evidence-thin area because these emergencies are thankfully rare, which makes it nearly impossible to run large, randomized clinical trials. Doctors are really flying by clinical judgment here.
And to make the ICU doctor's job even harder, they have to deal with mimickers. If someone is critically ill in the ICU with something completely unrelated like severe sepsis, their body will intentionally alter its thyroid hormone metabolism to conserve energy.
This is such a tricky situation.
Right. This is called sick euthyroid syndrome. Their thyroid labs will go completely haywire and look like severe hypothyroidism, even though their thyroid gland is perfectly healthy. It's the body basically playing dead to survive the sepsis.
And if a doctor misinterprets those labs and gives that sepsis patient massive doses of thyroid hormone, they can do severe harm. You also have to constantly worry about the adrenal glands during these crises.
How so?
Well, thyroid hormone naturally accelerates how fast the body metabolizes cortisol, your primary stress hormone.
So if you fix the thyroid without checking the adrenals, what happens?
When doctors aggressively treat myxedema coma by giving thyroid hormone, they also have to simultaneously administer stress-dose corticosteroids. If they don't, the sudden spike in metabolism burns through whatever tiny amount of cortisol the patient has left. Fixing the thyroid unmasks a hidden adrenal crisis, and the patient goes into irreversible shock. Everything in the endocrine system is intimately interconnected.
Which is the perfect realization to bring this all back to you listening right now, because this isn't just some obscure textbook puzzle for ICU doctors. These conditions intersect with perfectly everyday, mundane medical events. If you have an undiagnosed thyroid nodule and you go into the ER and get a routine CT scan, that iodinated contrast dye they inject you with is a massive iodine load.
It can easily trigger thyrotoxicosis via the Jod-Basedow effect we talked about. Or consider amiodarone, a very common heart rhythm medication that is heavily loaded with iodine. It can trigger either a thyroid storm or profound hypothyroidism, depending on the underlying pathology of your gland.
Imagine just skipping a medication refill because you're traveling, or an elderly relative experiencing a severe winter cold nip. These everyday stressors can take a slow-moving, invisible chronic illness and turn it lethal in a matter of days.
This raises an important question for modern medicine. How do we manage risk when the stakes are this high and the diagnostics are this blurry? Because the mortality for both storm and coma remains substantial, even with the absolute best ICU care, the golden rule of critical endocrinology is that treatment must be empiric and immediate.
Treat what's in front of you.
Right. If a doctor suspects it based on the clinical signs, the fever, the heart rate, the altered mental state, they must treat it instantly. You never, ever delay life-saving beta blockers or thiamides while waiting for confirmatory lab results.
So what does this all mean? We started this deep dive talking about the illusion of the lab test, the expectation of a clean, binary answer printed out on a piece of paper. But what we've actually uncovered is that the human body is a masterclass in redundancy and buffering. Our carrier proteins bind excess hormones. Our receptors constantly downregulate to protect us. Our glands even have built-in emergency shutoff switches like the Wolff-Chaikoff effect.
It's an incredible system.
But when those buffers finally break under the weight of a second hit, they don't just quietly fail. They weaponize the body's own systems against itself, like upregulating adrenaline receptors to turn your own fight-or-flight system against your heart. It really makes you wonder, what other delicate metabolic tightropes are we walking every single day without even realizing it?
It's a lot to think about.
It definitely is. Thank you for joining us on this deep dive into the extremes of the human engine. Keep asking questions and never stop wondering about the incredible machinery of the human body.